हाँ तो ये भी नहीं चाहिए मालिक से चाहते क्यों नहीं है, कोई प्रॉब्लम है जरूरत नहीं है, नहीं रेस्ट्रिक्शन लग जाता होगा ना, कि फ्री एजुकेशन देना, ये देना, वो देना। एनएमसी के शब्द तो माननी पड़ेंगे। डीएनपी यूजुअली ऐसे हॉस्पिटल डीएनपी होते हैं। हाँ डीएनपी होते हैं, एमडी नहीं, वो जान के एमडी नहीं लेते हैं। यू आर राइट कि एमडी नहीं लेते हैं, लेकिन इसका रीजन मेरे को ध्यान नहीं आ रहा। डीएनबी तो उनको मिलनी है। मेरे ख्याल में वो फिर पीजी एंट्रेंस हो जाता है इनको, वो फिर सारा जो भी कोटा वगैरह है वो सब फॉलो करना पड़ेगा उनको सब। हाँ सरकारी रूल्स रेगुलेशन इम्प्लीमेंट हो जाता है। एमडी में ज्यादा फर्क नहीं मेरे को लगता है। एमबीबीएस के बिना भी होता तो है, आरएमएल में तो एमबीबीएस नहीं है ना, क्या हो गया?
हो गया सर, 3-4 साल
शुरू हो गया ना 4 साल से, उससे पहले तो एमडी था खाली।
हाँ इट वाज पोस्ट ग्रेजुएट।
आरएमएल में डीएम
नहीं पहले तो जब लेडी हाई में आरएमएल पे भी जाते थे, वो दिल्ली यूनिवर्सिटी वाले जाते थे कुछ दिल्ली सेंट्रल। 4 साल पहले, 4-5 साल हो गए उनको वापस। 2 यूनिट्स थी पहले 2 यूनिट्स थी, काफी सारे दिल्ली यूनिवर्सिटी वालों को देते थे। आप नहीं वापस चले गए
अब तो
उनके यूनिट वापस चले गए।
यहाँ का आर्टिस्ट बिल नहीं मिल गए, रीजन ये
जब मैंने सर
अभी बोले आज प्रेसिडेंट नहीं आएंगे हमारे
पीछे हैं सर।
अब आगे बात गलत है, प्रेसिडेंट को पीछे नहीं बैठना चाहिए, आगे आओ।
रीडिंग फ्रॉम द बैक सर, रीडिंग फ्रॉम द बैक।
लेकिन वैसे प्रेसिडेंट की शक्ल आगे से ज्यादा अच्छे से देख सकते हैं ना। बाय गॉड मैं आपको इतना 11 नंबर होगा।
Senior consultant respiratory and sleep medicine from Vedanta, Noida. He has extensive experience in pulmonary critical care and sleep medicine, and he's a graduate of MAMC and completed his MD from VMMC and DM from AIMS. He specializes in advanced interventional pulmonology, including EVAS and thoracoscopy and multiple procedures. I request Dr. Manu to kindly come over and start with the presentation. Also, the case will be moderated by Dr. Anirudh Lochan. I think he's yet to come. The case is going to be chaired by Dr. H.B. Singh and Dr. Vinod Kumar Gupta, both are senior consultant physicians and very senior members of our organization.
यहाँ पे बैठने की जगह है, वहाँ पे बैठो, तो वहाँ पे दिख पाएंगे क्या उसके।
Thank you, ma'am. Thank you, seniors and colleagues, for having me over. I'm Dr. Manu Madan. I'm senior consultant lead at Medanta Hospital, Noida. I did my DM from AIM, subsequently worked as assistant professor in VMMC in Safdarjung. From there, I went to Max Saket for a couple of years, and now I'm here leading the department. So I'll be talking about an interesting case regarding mediastinal lipidopathy. So we got a 65-year-old officer, government officer, height 5'11", weight 82 kgs, presented with a history of fever for 4 months, cough for 4 months, weight loss for 4 months, to a private practitioner in Kanpur. He did a CT. CT showed multiple mediastinal lymph nodes, as you can see, at 4R locations and subcranial locations. Lung parenchyma was grossly clear. So he advised for sputum investigations, as we do for most of our patients if he's running low-grade fever persistently. So sputums were done, gene expert was negative. AFB stain and culture was negative. Serum ACE was within normal limits. Serum LDH was within normal limits. He was trying to evaluate for both sarcoidosis as well as lymphomas. Peripheral blood smear was not showing any abnormal cells. USG abdomen was inconclusive. This is where his expertise ended. So what do we expect? क्या किया होगा उन्होंने? As most of this.
This, it would be, I think they will have to go with a EBUS guided FNAC.
So absolutely, this should have been the next step. But since he did not have any EBUS scope at his clinic, so he started empirical ATT. ATT was started, fixed dose combination was given. Accurate 4 tablets once daily. But fever and weight loss continued. It continued for another 2 months. This is when he went to a tertiary government care hospital. They evaluated for autoimmune conditions also. They did ANA, rheumatoid factor, ANCA, anti-CCP, ENA profile. Hypersensitive pneumonitis panel was also done. It was negative. And this is when they did what sir just said. They subjected the patient to EBUS TBNA. EBUS TBNA was done. EBUS TBNA showed cell block and cytology as reactive lymph nodes. No granuloma, no cells. Gene expert was negative. Again, I would like to ask, if you were in this condition, what would you have preferred to do?
Active pathology,
Yes, sir.
is one of the conditions of tubercular histology. I mean, tubercular histology, if there is a KGS granulomas and other findings, right, then it's okay. But then reactive lymphoid cell or reactionary histology is also considered as one of the type of tubercular histopathology.
Okay, sir.
So actually, reactive is very non-specific, and one should usually not start ATT without evidence of tissue diagnosis, tissue positivity, or more specifically microbiologically being positive.
Suppose,
I mean, but if it is not positive, then that situation is, of course, I've encountered many times. And is already on ATT for how long?
2 months.
2 months.
No response, fever and weight loss is persisting. And they have evaluated autoimmune workup also. Autoimmune workup is inconclusive.
So I remember in my house job days, when I was doing general residency in cardiac surgery, one of the PGs, and that this is the era obviously before even FNAC, it is 82. So one of the PGs that were doing person PG at that time was doing had exploratory property for a mediastinal lymph node diagnosis. FNAC, if it is not conclusive, then any other place PET CT वगैरह करके देख सकते.
But they did not do it at that center, sir. They could not do it at that center.
So that center it was not possible.
So
that is now a possibility.
So they concurred with sir. They thought that they are not finding anything else. So this could be because of underdosing of ATT. As I initially said, weight was 82 kgs. Accurate 4 tablets were given. Probably he required 6 tablets for his weight. So they changed the dose and thought that patient might respond to it. So they changed the dose, but fever and weight loss still persisted. This is the time when the patient presented to us. So this is the time when we realized that we have to do something about it. Most of the things have been done. So as you said, we went for whole body PET. PET showed us only mediastinal lymph nodes at 4R and 7 station. They were 2 centimeter in size, SUV of 7. This time we do not find any other site. So our purpose for doing PET was, there were 2 main reasons for doing PET. One was seeing the extent of disease and to find another site where we could sample. If we can't sample the mediastinal lymph node, can we sample cervical lymph node or abdominal lymph nodes? But we did not find anything else. So this time we repeated the EBUS TBNA, but with a novel procedure called mediastinal cryobiopsy. Here, as sir said, we had two options. If you are not getting anything positive, either go for an invasive surgery, VATS guided mediastinal or mediastinoscopy to sample mediastinal lymph nodes, or the novel modality which we have these days, mediastinal cryobiopsy. So we chose mediastinal cryobiopsy of discussing with the patient. And this showed EBUS TBNA cryobiopsy showed acellular material, Congo red positivity, and it was labeled as amyloid deposit. This is when we involved a hematologist and he suggested for fat pad biopsy, which again showed amyloidosis. And subsequently, patient underwent serum and urine protein electrophoresis, serum light chain assay, bone marrow, all of them revealed AL amyloid. Echo was done, it showed restrictive cardiomyopathy, and endomyocardial biopsy also was done, which showed cardiac amyloid. So, what I want to highlight is the role of more lesser invasive tests which can diagnose mediastinal lymphadenopathy. So, this has brought me to the science behind mediastinal lymph node sampling. So, the EBUS TBNA, we all know that it is FNAC. So, it's just like cervical lymph node. You put in a needle, do puncturing, aspirate aayega, and this will be sent for testing. You might be able to make slides, you might be getting a small tissue, but it's never a large tissue. So you want to sample these uncommon conditions, or you want to sample cases of malignancy, where you want tumor markers to be done, mutations to be done. You need larger tissue. So in those cases, these sampling techniques really help us. So this is why intranodal forceps biopsy and mediastinal cryobiopsy have evolved. Regarding literature behind these, so this was the largest study published till date on the matter. This was done by Ye Fan et al. And it was 271 patients, which compared EBUS TBNA with EBUS TBNA with cryobiopsy. And you can compare the yield, 93% versus 81%. So they found it was significantly superior to EBUS TBNA alone. Subsequently, we had also done a study on the same subject of 101 patients. This was the third largest study at that time, largest from India. And we've also found the same thing. EBUS TBNA alone was giving us 67% yield. Adding cryobiopsy to it was giving us 86% yield. And this has been published pretty recently, a network meta-analysis with the Ye Fan group. This includes Germans, Italians, and we have concluded the same thing, that EBUS TBNA with cryobiopsy has better odds ratio of 4.01 compared to EBUS TBNA alone in sampling mediastinal lymph nodes. So how do we do this procedure? So we enter the airway to a EBUS scope. EBUS scope is nothing but a bronchoscope having an ultrasound. So we enter the airway. As you can see, this is our EBUS probe, which you can see in the camera. This is the endobronchial vision. This is the mediastinal vision, the ultrasound vision. So this is the lymph node. So first step is localizing the lymph node. So if the lymph node is more than 1 centimeter, we can consider doing these kind of procedures. So once we have located the lymph node, first step is again doing EBUS TBNA. We are puncturing like we do in cervical lymph nodes, putting a needle inside. This is the needle. It is going inside. This is the ultrasound vision, and multiple times puncturing it. This puncturing will leave us a tract, very small tract, through which we'll put our instruments. Many times it's not big enough. So in that case, we have to put a cautery inside. So this is electrocautery, which you can see inside the lymph node as well, and the endobronchial vision here. So after leaving here, you can see the big hole here through which we'll put our scopes, put our instruments. So this is a forceps which could be put inside. This is a cryobiopsy probe. So this was put inside subsequently, and you get larger chunk of tissues which could be sampled. To conclude this case, EBUS TBNA has only 70 to 80% yield in best of centers. To increase this yield, cryobiopsy can be used, and it's relatively safer modality in comparison to VATS guided biopsy, as sir suggested. And regarding if you guys are interested in reading about pulmonary updates, this is a book we publish every year, Pulmonary Update, first and second edition, and third edition is in the pipeline, will be released soon. Thank you.
डॉक्टर मदान, एक रिक्वेस्ट है वैसे पर्सनल कि जैसे when we start saying it's a mediastinal lymphadenopathy, so I want to know what is a CT picture of a normal mediastinum, and when we will start calling it mediastinal lymphadenum.
So whenever we get sizes more than 1 centimeter of lymph nodes,
वही same subcentric है तो normal है.
subcentimetric, we can consider it can be benign or reactive. If it is more than 1 centimeter, then it needs to be sampled because it can be malignant, it can be TB, it can be sarcoid, it can be anything else.
मतलब सेंटीमीटर से कम है.
So we can consider it can be normal, it can be passing infection.
How did you manage it?
So what's the?
How did you manage treatment?
Said the patient was subsequently put on the chemotherapies, Dara, bortezomib, and patient is still going on with these therapies, second line, third lines. Patient is still on daratumab and it is going on. So a patient is under hematology follow-up. So no more my case.
The interest did you contact them like is he better fever wise and weight wise?
Fever and weight loss resolved, but his cardiac amyloid part is gradually worsening. BNP is rising. So he's looking for alternatives. He's looking for experimental therapies. Last when I contacted him, he was looking for experimental therapy in Germany, which is starting on a trial. So they are trying on those lines because although the disease is in remission, but it flares up, worsens a bit, ejection fraction decreases a bit, halts, then it worsens again. So, and moreover, the cost of the therapy is pretty high. He was a government officer. He has already spent 70 to 80 lakhs from his pocket. And he's under trial with the government right now. He has formed some group, Amyloid Society of India, which is trying to push the PMO to include amyloid as a rare disease so that every rare disease which is listed in the PMO gets 50 lakh of what do you call financial remuneration. So he's looking for that. So सर जब हम अंदर डाल ही रहे हैं तो जो हमने so firstly to put a cryoprobe we need a tract because cryoprobe is blunt. To put our cryoprobe inside the mediastinal lymph node we have to create a tract. तो पहले तो puncture तो करना ही पड़ेगा हमें. So if we are puncturing the lymph node, it's better to take a sample. That's what I'm saying. क्रायोपैप्सी करने के लिए पहले हमें ट्रैक चाहिए क्योंकि क्रायोप्रोब जाएगा नहीं mediastinal lymph node में. तो उसके लिए पहले नीडल से पंक्चर तो हमें करना ही पड़ेगा वो रास्ता बनाने के लिए कि क्रायोप्रोब वो अंदर चला जाए. हमें नीडल डाल ही रहा हूँ तो इट्स बेटर टू टेक अ सैंपल फ्रॉम इट बिकॉज द यील्ड इफ यू कंपेयर EBUS TBNA with cryobiopsy is superior to either EBUS TBNA or either cryobiopsy. So since you are putting in a scope, additional charges of cryobiopsy is around 10,000. But पूरा अगर EBUS करना पड़ता है that charge is around 70,000-80,000. So it's better we give the highest possible yield to the patient. Okay, we did not repeat it.
He's saying.
Hmm.
He's saying that only.
He said cryobiopsy only करते हैं.
Why not do cryobiopsy in every patient? What you said?
So in every patient, if we do both of them, we tend to advise our patients accordingly only. That 10,000 extra you can spend and we can give you a better yield of 85 to 90%. If you want to spend 10,000 less, yes, we can do the procedure for you, but it might be giving you a yield of 70%. So it's up to the patient to choose what he wants to do.
A very interesting case and a newer procedure for us, for me at least. It is a new procedure. I have not heard about this procedure. See, mediastinal lymphadenopathy is always a little tough topic for a physician. So, many times the even EBS is not possible because of a couple of reasons. One thing is the finances. The other thing is sometimes patient is not willing to get even it is a messy procedure. So in that case, many times that go without a tissue diagnosis. Can there be some guidelines without a tissue diagnosis? Or can be done?
Without the tissue diagnosis, the best thing which we can treat is again TB. If it is malignant or sarcoid, that is something we cannot treat. So if patient is not willing for mediastinal sampling, then that is the only thing we can do. That is why when we did PET, our plan was if we can find something else in the body so that EBUS can be avoided, a repeat procedure can be avoided. But unfortunately, we did not find anything else apart from the mediastinal lymph nodes. So we had to sample it again. And when comparing to VATS biopsy, VATS has own challenges. Yesterday only I got a patient of VATS guided mediastinal sampling which was done in 21. Post that there was splenic nerve injury and patient has landed in diaphragmatic weakness on the left side. So it has own complications. Yes, it might happen 1 in 100, but it can happen. So that is there.
Dr. Pankaj felicitate the speaker.
It's called cryo. Are you freezing the tissue? Are we doing some cold procedure? Yes, sir. Freeze the tissue and remove freeze the tissue.
Next case for the afternoon is the interesting case for Dagapia. We presented by Dr. Neha Sharma. She is third year DNP resident at Max Specialty Hospital, Vishalgi. It is going to be moderated by Dr. Kamakshi Dhamija, who is senior consultant neurologist, Max Specialty. Going to be chaired by Dr. B.K. Gupta, senior consultant neurologist from Pushpanka.
I'd like to put Kamakshi and I think for some time that you can in this forum. Dr. Kamakshi up here is a Indian neurologist at Max Specialty. Very young and very active. And just like you this body.
So I did my MBBS from J. My MD from Safdarjung Hospital, Delhi. Then I done my DF from Jindal. And then after that, 1 year fellowship in technology and MS I've done in management. After that, I was faculty in Safdarjung Arden, and then finally I joined neurology at Max Specialty.
That's my orders in your quite we have made a lot of good diagnosis in the orders for the CDP forum.
Good afternoon, respected moderators and all my seniors. I am Dr. Neha Sharma, and today I am going to be presenting an interesting case of ataxia. Patient information: 64-year-old male with no significant past medical history, non-alcoholic, non-smoker, no history of diabetes, hypertension, hypothyroid, or any cardiac history or any history of CPA. Presenting complaints: he presented to the OPD with complaints of gait imbalance and truncal ataxia since 2 days and bilateral lower limb weakness since 1 day. History of presenting illness: patient was apparently all right till 1 day prior. Then he developed sudden onset gait imbalance. Suspecting stroke, he was taken up to an outside hospital where neuroimaging was done and MRI brain was found to be normal. The next day, he went downstairs to the park after having his breakfast. His friends noticed that he had profound gait imbalance and was now seeing that he required support while walking. He was then taken to our hospital. There was no associated symptoms like headache, vomiting, fever, vertigo, diplopia, dysarthria, dysphagia, facial asymmetry, any bowel bladder involvement, no history of loss of consciousness, any seizures, no history of cough or burning micturition. Timeline of the symptoms: on day 0, that is on the day of admission, He had gait imbalance and truncal ataxia. Over the next 24 to 48 hours, he developed progressive bilateral lower limb weakness and ascending involvement of upper limbs. Past history, no significant known past medical history. No diabetes, no hypertension, hypothyroid, cardiac, or any CVA history. No previous hospital admission or any surgery. Personal history, vegetarian by diet, normal bowel bladder habits, non-smoker, non-alcoholic. Family history was not contributory. Mental status, conscious, well-oriented to the time, place, and person, GCS E3, V4, M5. Vital signs, BP 150 by 70 mm of 50 pulse, 88 per minute, respiratory rate 16 per minute, SpO2 98% on room air. These were on the time at the time of admission. General physical examination, general condition was fair, conscious, cooperative, well-oriented to the time, place, and person. Build and nourishment was average. Hydration was adequate, pallor was absent, no icterus, no cyanosis, no pedal edema, and no lymphadenopathy. Initial neurological examination on day of admission. Cranial nerves were found to be intact, power, upper limbs 5 by 5 bilaterally, lower limbs 5 by 5 bilaterally. Reflexes were preserved initially. Pupils bilaterally equal and reactive. Meningeal signs were absent. No neck rigidity, Buczynski, Kernick negative. Cerebellar signs were also absent. No dysdiadokinesia. Normal finger nose test, normal nail heel test bilaterally. Truncal ataxia was present. Romberg was positive. Since Romberg was positive,
Sudden onset ataxia, no other deficit. MRI normal. So I think we cannot comment about the Romberg when there is a truncal ataxia or any type of ataxia like this. So what was your diagnosis first? What did you suspect?
initially it was an acute onset ataxia, so we were suspecting a case of cerebellar stroke initially. But since the MRI was normal, there was no stroke found.
Agree with this? Can be MRI negative stroke in 48 hours initially, but if the patient we suspect stroke clinically and nothing else, so we have to treat it as a stroke only,
Yes, sir.
not waiting for the MRI.
Initially it can be negative.
And angio, MR angio at that time.
MR angio was not done there.
So many times, MRI can be normal, MR angio can be normal, and patient should be treated as a stroke.
Stroke.
If there is window period, if the patient is in window period.
Yes.
So,
What was the catch in this case was the patient came to us on day 2 of the presentation. Day 1, he had developed sudden onset imbalance. Apparently, sudden onset, we won't say sudden acute imbalance. So he visited somewhere in the periphery, and obviously, when he underwent MRI pain, and it was found to be normal. So the next day morning, he had some worsening. So after that, he visited in the hospital, and she was not the first to examine the case. It was our neurology resident. So that resident examined the patient on bed, and I received the call. Probably it's a peripheral vertigo and chakkar aati. Certainly, chakkar aana is like a layman diagnosis. जिसको orthostatic hypotension है, जिसको ataxia है, जिसको vertigo है, सबको chakkar आता है. So the resident told me there are no deficits. So probably yeah. So the catch here was he didn't make the patient stand and examine him. So when the patient was made to stand bedside, he was not able to balance, and there was gross ataxia walking. So examination that time, of course, reflexes were there. They were hyporeflexia, and it was still progression of the symptoms. And very minor patient had some like incidentally the wife gave some water, and there was certain aspiration signs. So of course, with a negative MR, second time also, and again MRI brain was treated. The second time, stroke protocol MRI they were negative. So it was something else apart from the stroke. So that time we planned NCS, NCSF, everything. So by the time all this, it was a Saturday when it was there. Sunday I was down this morning. Patient was grossly in respiratory distress, aspirated RRO from loading SPO2. So based on while that time, of course, NCS was not done. CSF showed my, you are carrying the CSF reports?
Yes, ma'am.
Showed them also.
One question. So,
Yes,
how common, if you're suspecting it to be a cerebral etiology, how common is it to have just a frontal ataxia or ataxia without any other cerebral signs? Because it says cerebral signs were absent. How common is that? Or how uncommon? You answer it.
So usually we will get some kind of sign, like we can test for the finger nose test or nail heel test. There will be some kind of incoordination present. Like in this case, there was only ataxia, and ataxia is it is not so specific because all the rest of the signs are negative. And the neuroimaging is also normal. There is no stroke or any hemorrhage.
What it means is that can cerebral ataxia present just like truncal ataxia, nothing else? What is it asking? So just to answer, one is it is in the process of progression. So when there is just involvement of the one miss, so two presentations, ataxia and speech dysarthria. But the patient is having ataxia and it is already 48 hours. So unlikely there is some cerebral pathology because speech is not involved. And then of course second diagnosis are coming to what was rapidly progressive and maybe one.
Evolution of the neurological findings within the next 24 to 48 hours. There was a rapidly progressive ascending type of symmetrical weakness, lower limbs followed by the upper limbs, power upper limbs 2/5, lower limbs 2/5. Development of flaccid quadriparacels was seen. There was global areflexia. No sensory level was found. Superficial sensations remained intact. Patient was intubated and put on the mechanical ventilator on second day of admission itself in view of the respiratory distress and desaturation. Lab findings. TLC count went up to a maximum level of 17,000 with neutrophilic leukocytosis. On the EBG, the arterial pH was found to be 7.1, lactate 13.4. There was lactic acidosis and severe metabolic acidosis. Mild renal dysfunction was found, and mild electrolyte imbalances were also found. ET culture found Acinetobacter baumannii as the growth. CSF findings. CSF was done on day one itself. It showed albuminocytological dissociation. CSF protein was found to be raised, 88.6 milligram per deciliter, and TLC count 15 cells per mm cube. Imaging, CT brain was found to be normal. No evidence of any acute infarct or hemorrhage. No structural lesion. HRCT chest showed mild diffuse emphysematous changes with fibroparenchymal lesions in the bilateral apical segments and fibrocystic lesion in the left upper lobe. Peribronchial thickening with patchy A-space opacification in the posterior dependent aspect of the bilateral lower lobes and adjacent left lingular segment. Nerve conduction studies, it showed predominantly the demyelinating sensory motor polyneuropathy. So differential diagnoses were cerebellar stroke, toxic metabolic encephalopathy, sepsis-associated neuromuscular weakness, and Guillain-Barré syndrome. But initially we were suspecting it to be a case of cerebellar stroke, but since there was no cerebellar signs and neuroimaging was found to be normal, and later on there was ascending type of weakness, bilaterally symmetrical, so it was ruled out. Then toxic metabolic encephalopathy, it was ruled out because the patient involved the patient had symmetric ascending weakness first. The neurological complaints preceded the metabolic derangements, and metabolic derangements were not severe enough to say, and the consciousness remained intact. Then sepsis associated neuromuscular weakness. The sepsis happened later on, and the weakness was found first. The neurological complaints happened first, and the neuroimaging was normal, and it goes more in favor of the Guillain-Barré syndrome as per the clinical progression and the CSF findings also. Sir, yes, sir. But later on, as the sepsis developed, then the GCS gradually it was found to be low. Then when the patient had not much consciousness. Yes, ma'am.
So encapsulation was never diagnosed.
It was ruled out, just a differential diagnosis.
That sensory system was normal. In Guillain-Barré, generally it's a glum and stroking type of this thing.
So initially on because it can be normal here because the patient has sudden worsening. It all the symptoms happened suddenly and within a matter of 2 days itself. So what, sir?
बाद में ये Guillain-Barré के और not
Later on, he had all the typical. Yes, sir.
हाँ,
Yes,
Yes,
that is typical variant which everyone of us knows. So what she is probably trying to emphasize here is GBS does not always manifest with this sensory motor weakness, where you find some large fiber sensory deficit motor weakness. There are certain ataxic variants of GBS also. There are some other variants which are of course rare, but should be kept into cognizance once such a patient presents to us. One is an acute ataxic variant of GBS. Probably when this patient presented to us at day 2 of illness, the differential was ataxic variant, but eventually he developed corticostesis and it was an GBS like picture by the end of 4 to 5 days. Some rare variants, probably you are showing in the next slide. Patients can present with just failures of hyperbrachial, just profound degradation difficulty, pharyngeal weakness, and some other lip deficits. Then there are certain variants where patients just have paresthesia and facial weakness. That is called a bifacial paresthesia variant. Then pure autonomic variants are also there. Otherwise, no deficits, motor, sensitive, and also sorry.
We have seen single limb involvement.
Yes, focal variants are also there.
40 years back.
Yeah.
Some of the
The
episode.
point here to emphasize is apart from the usual variants, there are certain rapidity of progression and the fact that there was grossly an ataxic picture, which eventually, of course, evolved into a typical picture. Such sort of their presentation should always be kept into mind by such patients.
one variant of GBS which is very fulminant and it's
So probably this was a fulminant variant because he was ventilated at day 3. So it was a severe variant, but eventually he recovered very well. So the therapies which we offered him was plasma therapy. Yeah,
First examination, there was no deficit and all the reflexes were normal.
So day 2 of presentation,
Day two
we
पे
got
आ गया.
reflex. Day 1 we didn't see the patient.
All the reflexes were normal.
Only at historically it was
But historically, Guillain-Barré में all reflexes present is very unknown.
in the ataxic variant reflex.
How the patient NMOP
What was the day of the CSF and NCS?
CSF studies was done on the day second of the admission itself.
Was the way it takes a week to psychological.
Yes, sir.
And the first is critical and the evidences. And of course, if you suspect very fast progression, the patient is intubated. And of course, Kamachi's favorite nodopathies and seeing the neuropathy. Did you send that in this patient? They came to be negative. Because the treatment line is same except that you add steroids to the plasma exchange.
So this patient has an atypical presentation of GBS, Therapeutic intervention. This patient was managed in the ICU. 7 cycles of Plex were given in total. Broad spectrum antibiotics were given. Aggressive fluid resuscitation, correction of the metabolic acidosis, renal and electrolyte monitoring, supportive care, serial bedside spirometry, and DVT prophylaxis, and early physiotherapy. Outcome and follow-up. There was neurological improvement after the Plex, stabilization of the metabolic parameters. Patient was weaned off from the ventilator support, continued the physiotherapy as advised, and there was gradual gait recovery as well. The patient improved with the Plex itself.
Plex and IPIG both are two. In such turbulent variants, there are things to consider before we take up a Plex or IVIG. Probably the rapidity of response with Plex is much more than in IVIG because the latency of effect of IVIG is usually around 2 to 3 weeks. So in such a turbulent variant, we don't wait for that. Secondly, there are, of course, the literature doesn't favor this, but somehow we have seen some patients who respond better with Plex. Some patients might respond better with IVIG. But in case the patient has already been offered IVIG and has not responded to that, and it's worsening case, we would be stuck. Because if you give IVIG for next 2 weeks, you cannot do Plex.
But you wanted to be aggressive in the first place.
Because he was already ventilated by the HT. But if they are offered Plex and the first time IVIG can be started in the next one. But hopefully this patient had recovered by the time he received 7 cycles of Plex, so we didn't consider this.
Here we have a video of this patient on follow.
This aqua exchange was done alternating or every day?
Sir, every day.
Is the response and then subsequently out.
He showed complete recovery on follow-up, and he can walk normally, as you can all see. This is the before and after picture of this patient. So ataxia as an initial manifestation of GBS is very uncommon, and it is seen in AIDP variant like in this case, and in sensory ataxic GBS. Clinical progression remains the most important diagnostic clue here. Not all acute ataxia in elderly patients is stroke. GBS should be suspected when ataxia is followed by ascending type of weakness and reflexes are lost. Normal neuroimaging does not exclude the serious neuromuscular diseases, and early initiation of plasmapheresis helps in improving the outcomes. Guillain-Barré syndrome, it is an acute immune-mediated polyradicular neuronopathy, which is characterized by rapidly progressive ascending type of symmetrical limb weakness with areflexia or hyporeflexia, variable sensory cranial nerve or autonomic involvement, typically post-infectious. Pathophysiology, there are autoantibodies triggered by the infection, which causes molecular mimicry and then immune attack on the peripheral nerves, roots, or their axons. AIDP, acute inflammatory demyelinating polyradicular neuronopathy. It is the most common variant seen in 70 to 80% of the Western countries. Pathology, immune-mediated demyelination. T-cell and macrophage attack on the Schwann cells. Clinical features, ascending symmetric weakness, proximal plus the distal muscles. areflexia. Mild sensory symptoms can be present in the form of paresthesias. Cranial nerve involvement is common, like the seventh nerve. Reflexes are absent. CSF shows albuminocytological dissociation. Nerve conduction studies show demyelinating features like the slowed conduction velocity, prolonged distal latencies, and conduction block. Acute motor axonal neuronopathy, it is common in Asia, China, India, and Latin America. Pathology, there is immune attack on the motor axons. Anti-GM1 antibodies are common. Most often it is post-Campylobacter jejuni infection related. Clinical features, there is pure motor weakness and no sensory symptoms. Rapid progression is seen. Reflexes may be preserved initially. CSF may be normal initially. Nerve conduction studies, reduced compound motor axonal amplitudes, and normal sensory studies, no demyelinating features. Prognosis is often rapid recovery if the axonal degeneration is minimal. Acute motor and sensory neuronopathy. Severe axonal variant pathology is the axonal damage of the motor and the sensory nerves. Clinical features, there is severe weakness along with the marked sensory loss as well. So early respiratory failure is common here, and autonomic dysfunction is also frequently associated. Nerve conduction studies showed reduced compound motor action potentials and reduced sensory neuronal action potentials. And axonal type of pattern is seen. This has got the worst prognosis and prolonged recovery. Residual deficits are common. Miller-Fisher syndrome, there's the classical triad of ophthalmoplegia, areflexia, and ataxia. Pathology is the anti-GQ1B antibodies. Brainstem and cranial nerve involvement is also seen here. Clinical features, there is prominent diplopia, gait and limb ataxia, minimal limb weakness, and pupillary involvement is common. CSF shows albuminocytological dissociation, excellent prognosis, and near complete recovery. Pharyngeal, cervical, brachial type of variant. It is rare, and clinical features, it shows weakness of the pharyngeal muscles, involvement of the pharyngeal muscles, neck flexors, and the involvement of upper limbs as well. Lower limbs are usually spared here, and facial weakness is common. Upper limb shows areflexia, and antibodies involved are anti-GT1A. Pure sensory GBS, it is very, very rare. Clinical features, acute sensory loss, severe paresthesias, ataxia due to the sensory loss, and no motor weakness. Nerve conduction studies show sensory axonal neuronopathy. Autonomic variant. It often overlaps with other variants. Clinical features include the BP fluctuations, cardiac arrhythmias, urinary retention, ileus, and sweating abnormalities. Bickerstaff brainstem encephalitis. It often overlaps with the Miller-Fisher syndrome, but the catch point here is that the patient has got hyperreflexia and altered sensorium. Instead of areflexia, there will be hyperreflexia and altered sensorium. Antibody involved is anti-GQ1B. Ataxic variant of GBS, like in this case, the sensory ataxic type, there is immune-mediated peripheral neuropathy characterized by prominent ataxia, areflexia, minimal or no limb weakness. In our case, it was atypical GBS at first, which later on progressed to the typical variant. So minimal or no limb weakness and preserved consciousness. Pathophysiology, immune-mediated involvement of large sensory fibers, that is the proprioceptive afferents. It leads to sensory ataxia, and often it is associated with anti-GQ1B antibodies. Clinical features, acute or subacute onset of the gait ataxia, limb incoordination, positive Romberg sign, areflexia, minimal or the absent motor weakness, no cerebellar signs, and consciousness remains preserved. CSF findings, albuminocytological dissociation. It may be normal if the CSF is done early. In the nerve conduction studies, sensory neuronopathy pattern, reduced or absent sensory neuronal action potentials. Motor studies relatively are preserved. In relation to the Miller-Fisher syndrome, the ataxic GBS, it lacks the ophthalmoplegia. Ataxic variant is basically the incomplete type of Miller-Fisher syndrome. Thank you.
questions and queries. The closing comments.
So, the whole idea of presenting this case was obviously recognizing some repair in GBS because starting the treatment on time is the choice of the treat also would be a decided factor because already it was into a convenient phase when it came and starting next early in reality affect the outcome at the end also and as the last video is shown, both the husband and wife were smiling at the end of the video, but probably when they came up, all the questions were bombarded at the starting, what happened, how happened. But then they both smiled at the end of the video and thought it is all worth it.
So, did you suspect on the day one as a GBS?
So, the cashier were two things. One
The
was
patient actually followed my patient. The patient of average for I think 5-7 years. Fellow already come. So he came with this concept. He came to my OPD. Right. I said okay. Now चक्कर आ गया तो बीपी भी हुआ तो कोई बात नहीं. But जब वो खड़ा हुआ तो मतलब he was just a taxi. मैंने कहा यार where is no process मैंने कहा तो तुरंत एडमिट करा तो तुरंत ऐसे आई मारे शुरू. तो हमने जाने दिया तो we just admitted the patient and that the story started from there only. And then community took over.
His question was really suspect. Or
नहीं डॉक्टर पंकज ने कह ही दिया पहले इन्होंने भी स्ट्रोक सस्पेक्ट किया
question
That
of
is
his
very
he
rapid.
was answering whether she suspected what you are. Can you suspect this?
date of infancy progression of symptoms is a red flag.
नहीं आपने कब सस्पेक्ट किया जी
So he came on day one onset, still progressing by the time he came. And the normal MRI 2 times. It's of course assumed to be normal.
They were the ascending, this is upper limit. That was the point. When
Day 3. Second day.
the peripheral neuropathy.
Into hospitals were also involved.
By day
I mean, day 2 it was because barring clinical.
डॉक्टर बीके गुप्ता ने बताया ना 48 आवर्स तक तो हमारा नॉर्मल चलता है
but
Is when the patient ends with you. I'm wise a doctor when the patient comes to me of the second day. I would say it. So we'll say I'm the right doctor who got the diagnosis. So on day one, everyone will be like 1 or 2 differentials. Unless they suspected that hyporeflexia on day 1, so stroke, but there were no risk factors at all. Reflexia was definitely there. And no other cerebellar sign was again a little odd against it. As I said, like there's a brain involved. Then ataxia plus dyspepsia. That will be there. This patient has subsequently full blown. So only 2-3 noises in clinical practice, we don't do CSF so fast. We do NCV on day 1 and shows minimalistic and areflexia, as you said, is hallmark. Unless it is a typical variant having not. So maybe hyporeflexia, areflexia, and truly one patient of same age, we admitted in Pushmani, we thought it is a stroke only when we treated. But then we found the patient is, it becomes how have you examined the patient. So what patient not showing response. आपने हैमर लेके नहीं घूमते कई बार आपने एग्जामिन किया हैमर देखा रिफ्लेक्सिया डायग्नोसिस करेगा you gave IVG patient posterior circulation stroke can mimic like a GPS that is particularly the mega patient variant and patient is completely normal and we are also happy and this you should be keeping in mind stroke and headache.
Doctor,
How common is GBS in an elderly person?
One is that is little less and it is tolerant time. More than 55 years of age, 55 patient DBS. So we expect more complications. And this patient has just progressed 48 hours. Now the diagnosis these days is changing. So more nodal. So they, GPS takes time to worsen gradually many times. 48 hours. Now within 48 hours, diagnosis has changed. Nodal. So nodopathy is you're giving plasma exchange and steroids together. And then followed by rituximab. So nodopathy is different entity than GPS like presentation. So we are not calling it as a GPS.
did a PET, that was normal. We did a paraneoplasticify, that was normal. We also tended to rule out sometimes acute onset CIP can present the GPS like people. So immunofixation electrophoresis also done, that was also very good. So probably what we were dealing was the monopathic part of the immune-mediated neuropathy which we got launched. So I was telling neuropathies, we test some antibodies. Neuropathin antibodies are there. So they were and they also came. So probably it was all a monophasic party.
These antibodies are in the CSF or very.
So serum and CSF, they can test it. But usually, serum, the CSF का जो specificity sensitive cerebellar, in patients with some central phenotypes, cellular facial symptom.